She'll be speaking on SICS through 3 mm incisions. So we are going from 6 mm, 7 mm to 2 mm.
A very good morning to all, esteemed guests on the dais and the fellow delegates. So yes, it is possible. We have all seen from 7 millimeters to 6, and I think I thought I was the smallest, but yes, we have seen 2 millimeters as well. So skipping all the introductory part. So in methods, and this was my study. It was total 40 patients of cataract was taken, and most of them were pre-senile, immature, and traumatic cataracts and soft cataracts were also included. So exclusion was hard brown cataract senile patients and patients with pre-existing corneal pathology and poor uncooperative patients who had poor general conditions. So a 3 millimeter scleral incision was made at 12 o'clock with the BP handle and 15 number blade, and then opened with the crescent knife. Anterior chamber was entered with 3.2 keratome, and in some cases later on I tried the clear corneal incisions also. Here I'll just show you a short video. I am always propagator of a frown incision. I rarely make a straight incision. So as we have already seen in the previous lectures about how it is astigmatic neutral and away from, so these are the incision parts. So coming to the capsulorhexis, in manual phacophragmentation, a good mydriasis is essential, and a capsulorhexis was made with a cystitome through a side port incision and MVR blade. After the capsulorhexis, the anterior chamber was entered with a 3.2 millimeter keratome. Balance salt solution was injected, and the between the anterior capsule and the cortex, so in the immature cataracts, I avoid using Bluerex dye, trypan blue, and when the glow is very properly seen, only in the mature cataracts, then the trypan blue dye is used. So coming to the main topic of manual phacophragmentation, once the nucleus is luxated into the anterior chambers, sodium hyaluronate is injected around in the anterior chamber. The nucleus is then fragmented by blurring by using two dialers and a chopper or a Sinskey hook through two side ports, and applying opposing force in the middle of the nucleus manually. Thus the nucleus gets fragmented into or more fragments of, and these are then expressed out either by visco-expression technique or the irrigating vectis. For my residents, I always advise them to use irrigating vectis techniques, which is makes the delivery of the nucleus very easier, and in the learning phase it is very helpful when students are struggling to get the nucleus out of the anterior chamber. And then the remaining lens cortex is aspirated by a Simcoe's cannula. So now that the nucleus is in the anterior chamber, with the help of a Simcoe cannula and the Sinskey hook or a chopper, it is manually phaco-fragmented into pieces, and it is then the nucleus is, the fragmented nuclear parts are then delivered out of the chamber. So it is assisted from the side port incision with the help of a Sinskey's hook. So another case. So sometimes it is done in the posterior chamber, the fragmentation, but to avoid corneal damage. But preferably in pre-senile cases when there is, the nucleus is very soft and there is good hypotony. And then the prolapsed pieces are then nuclear pieces are then prolapsed in the NTA chamber. I thought I still have 6 more minutes. So, the viscoelastic materials is then injected, and foldable IOL implantation is done through the 3 millimeter incision. So post-operatively, corneal edema and striate keratopathy was significant in few cases, but usually it resolves within a couple of days. And these were the observations and the results. So there's no significant differences in BCVA in post-operative patients of both the group. However, phacoemulsification leads to a lower rate of astigmatism, but there was no difference in the post-operative complications, and cornea was quite okay. So, to conclude, soft nuclei can be easily manipulated through the 3 millimeter incision, and corneal complications are similar, and this is very shorter learning curve, and no higher resources and no machine dependence is there. So PG students can be taught implanting foldable IOLs in these cases. Thank you so much for your kind intervention.